Hello, 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 everyone. We are live on the radio in the San Francisco Bay Area on KDOW. We're going to be streaming in just a few moments. So stay tuned. You don't want to miss this episode of The Heart of Innovation.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kym McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone, and welcome to the show. This is the Heart of Innovation, and we are going into April, which is Limb Loss and Limb Difference Awareness Month through the Amputee Coalition. And so since peripheral artery disease, which we talk a lot about here on the show, which is poor circulation in mainly the legs, it can lead to amputation. We wanted to feature several patients this month who have experienced an amputation due to peripheral artery disease, and they've lived to tell about it, and they're thriving. And the one today that we are featuring is actually not only an amputee advocate, but he's also a diabetes advocate. He's been to the White House. He has literally been focusing on trying to create the change that we all want to see in diabetes and PAD care. We're going to get to Robert Parant in just a moment, but first, let's welcome my co-host, Dr. John Phillips. Hello, hello, hello.
Hey, how's it going? Happy Saturday. We're live. Thanks for everybody for joining us. It's 70 degrees and cloudy in Columbus, so this is the best weather we've had in months. So everybody's stoked to get outside. But yeah, looking forward to a fantastic episode. Really germane topic. I just got a text about a lady that I helped get some better blood flow, but she required some minor amputations. Just saw another gentleman Thursday. We did a repeat procedure after he was told he was going to lose his leg, but we were able to preserve the leg. He lost his piggies, unfortunately, on the right side, but he's doing okay. So yeah, very important topic, and can't wait to hear from Robert and get his perspective, not only on that, but just kind of raising awareness. Obviously, diabetes is a big issue too, so we can chat about that too. So we're going to have a good time.
I think it's really important to mention just at the onset here is that when it comes to PAD, amputations can be preventable with an early diagnosis and proper care and management and mitigating those risk factors, especially when it comes to diabetes. We had a phone call on our brand new Lifesaver hotline for the Global PAD Association, 1-833 PAD legs. So excited about that. Our PAD navigator, Douglas, was the first to answer that call this morning. And it was from the wife of a patient in Seattle, Washington. And she was saying that her husband is a type 1 diabetic, 62 years old. And in October, the doctors had done a lower extremity circulation test for the arteries, which is typically either an ABI, ankle brachial index, where they put blood pressure cuffs on your legs and your arms, measure the differential, or they'll do a Doppler, an artery ultrasound. And she said that they told him that he had some poor circulation, but didn't make a big deal about it at the time. So she figured, oh, it's just mild or moderate. Didn't think anything about it until literally just this month when he got an ingrown toenail and it spun out of control. And the podiatrist said, you know what? I don't think you're getting any blood flow to this toe. How often do you see that with these patients that the doctors wait until they're a toe stub away from amputation before they act?
I would say that story is, at least in my kind of orbit, very real, very frequent. Unfortunately, I think it's getting better since we're doing things like this and raising awareness. But I mean, I see a patient a week who trimmed the toenail too close or wasn't wearing appropriate shoes, got a little abrasion on the toe with risk factors like diabetes, kidney dysfunction, things like that. Next thing you know, it's a wound that's not healing. In fact, the lady that I got texted about this morning, who went to surgery for her amputation, and we opened up her blood flow on Thursday, I think it was. She said, I just kind of noticed a little bit of discoloration in the web space between, my digits 1 and 2, and didn't think much of it. And then next thing you know, it's like infected and has to come off. So, I mean, it's real. And I love the fact that we do this to raise awareness for patients and make sure we prevent amputations, because you said we can prevent a lot of these.
And it's interesting because you and I were just talking last night on the phone about the American Heart Association, a scientific paper that came out, and they said that women are actually more apt to being asymptomatic until they're a toe step away from amputation versus men. Sometimes there is a little bit more of indication. They may not report it, they may not complain about it, but at least with women, it seems like their presentation is atypical of what's going on.
Correct. I mean, from a coronary artery disease standpoint, blockages in the heart arteries, women present atypically as well, which is why when we're interviewing patients about certain symptoms, you kind of have to run the gamut of questions. And oftentimes, at least in my experience, women sometimes downplay their symptoms a little bit more so than men, which I think women are just tougher than men, obviously. And I get a little point there, but yeah, so it's important to make sure you press them a little bit more.
Yes, exactly. And the woman that called in said she actually gave a shout out to Dr. John. And I know that you don't like being called Dr. John, but we all call you Dr. John. But
No,
it was fantastic that when she called in, she said her husband, because I asked her, is your husband doing any sort of exercises to improve circulation because he's non-weight bearing at the moment and can't walk? And she said, yes. Actually, the ones that Dr. John talked about in a recent episode of your show, I am having him do as many times as we can.
Sweet.
That's amazing that she knows Dr. John, and she is following Dr. John's advice.
Well, I'm glad I can be of help. But I will tell you, I know we've got 2 minutes left, but exercise is so important. The more you exercise, the less likely you will die of cancer, and the less likely you will have cardiovascular events. So get out and move, walk, run, whatever you can do, but exercise.
Yep. At the very least, move your feet, do the foot alphabet, rotate those ankles. Yep. And make sure you're doing the push the accelerator button, pull it back. Just every little movement helps, especially if you are bedridden or, while you're just sitting in a chair watching TV. It's fantastic. And our friend Douglas, our PAD navigator, will tell you, even take some paper plates or some towels and push them back and forth and back and forth and back and forth on the floor while you're sitting there. And on that note, I think let's go to break a little bit early because I'm really excited. I see Robert Parant sitting there in the sidelines, and he's waiting to get in, and we're going to have your moment of inspiration coming up next. So stay with us right here on KDOW. Don't go away.
Leg health can indicate risk for heart attack, stroke.
Okay, so
great segue out.
Woo! Sorry. That was a good conversation, though. I thought that was really important.
It was. We can go on forever. You know that, though.
Yeah. But I love the way you explain things. But you know me, when I get a call on the Leg Saver hotline and it's someone that's just like, well, Dr. John, or I watch this show. And we get a lot of that, which is amazing. We have people.
It's sweet. It's good to know.
We have a gentleman in Ireland that watched the show and saved our patient who's still in the hospital at Tampa General, and he was at a nearby hospital, which the family deems the leg morgue, and we were able to get him because the daughter watched our show, or because her friend from Ireland says he's an avid watcher of all of our broadcasts, learned so much, and shared the video of the episode with Dr. John Davis.
Oh, yeah.
Where we talked about the bypass. So yes, and Douglas says Dr. John the bomb.
Thanks, Douglas.
Oh, no.
But again, we're not doing anything crazy here. We're just talking about things that I run into on a daily basis, but just trying, thankfully, and we're blessed we have a platform and a microphone, a very large microphone.
I know, you made me get the same one.
Oh yeah, definitely. It's awesome. But yeah, I mean, we're lucky to have that. So It's a blessing. It truly is.
11:30.
Chris, do you mind kicking off the segment with the moment of inspiration music?
Sure.
Thank
So
you.
you hit the regular music and then just kick it off, and then Dr. John will wait for you to hit that music.
Yeah, I got it.
Okay. Thanks, Chris. Robert, I promise we're going to get to you in the show.
No problem. Enjoying
It's
the
a good conversation. It's good, right?
Yeah.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Dr. John Phillips, spectacular vascular moment of inspiration.
It's not often you get your name mentioned twice in about 3 seconds on the air. So,
Well, you said you got the microphone, so
you know what? It was funny because it's kind of like, why are you allowed to talk? Because I have a microphone. Anyway, so I'm on my World War II kick of late, and I was thinking about resiliency in the setting of Limb Loss Awareness Month, and just how resilient you have to be if you lose a part of your body. I mean, it's just, I can't imagine it. So I found a quote from General Eisenhower. I'm sure you've heard it, but I kind of like this one, and I'm interested to once we bring Robert on to see what he thinks. But Eisenhower is quoted as saying, "What counts is not necessarily the size of the dog in the fight. It's the size of the fight in the dog." So I don't care how big or small you are, if you got to fight. And that's what I tell my patients too. I will fight for your toes and your leg and whatever I can, as long as you're willing to fight. And sometimes folks throw the towel in a little too early. So this episode is dedicated to the fighters, and it sounds like Robert's one of them. So we should probably bring him on, huh, Kym?
I would love that. Robert, jump in here because it is so true. You've been through it all. You definitely have a lot of fight in you, from diabetes to PAD, ultimately to becoming an amputee.
Absolutely. And you started the conversation off. I'm the poster boy for that, where, I had the symptoms. It could have been avoided if it was handled correctly. So I am very thrilled and honored to be asked to be on this show today. I can give a lot of experience in a couple of different areas. I'm a father, grandfather, retiree sales executive in the pharma health insurance area, believe it or not, and was diagnosed with type 1 diabetes as I went to college at 19 years old in 1972. The dark ages where we really didn't know our blood sugars for 10 years, other than urine. Which is 4 hours off and not accurate, and a whole bunch of other things as far as the diabetes and support that I had received. There's nothing like there is today as social media. You can gain knowledge, you can talk to people. That wasn't available back then, so I was all alone, but I didn't really get as crazy about it as I do today because you have the technology on you. Oh, my sugar is this, my sugar is that. So there was a lot of years where I did not know my blood sugar, but I was always active, played rugby after I got diagnosed, runner for 15 years, biker after I had some foot issues. So I guess I'll start with the personal journey of feelings in my legs, which was nerve issues, and the start, in my opinion, of PAD, which was probably in the early 2000s. I went for an EMG. They saw some discrepancy in what it should be, but nothing was ever done.
It's interesting you say that it starts with the nerves, because a lot of doctors will say, well, your nerve issues, they're firing just simply because of your diabetes. But the American Diabetes Association had come out and said something to the effect of, don't quote me on the exact percentage, but I think it was more than 85% of all of this neuropathy, so-called neuropathy, is actually circulation related. And it turns out it was the case in your situation as well.
Yes, I definitely agree with that. And like I said, I was always exercising. I was always working out, watching the sugar and everything else. So when this started to occur, I knew it wasn't normal. I went for the EMG and they said, okay, no, it's just minor at this point. It will, you just keep an eye on it and go to your vascular guy. So as time went on, I started to experience it more and more. As I walked, I was in sales and always out in the field, walking in shoes. Back in those days, we wore a suit every day, going on my calls. And lo and behold, I got a blister on my big toe. So this was probably around 08, 09. And of course, I knew I was very up on my diabetes knowledge and what could go wrong. I always was reading about it, so I was, pretty knowledgeable about the complications.
And Robert, can I just ask you? Obviously, you seem very insightful and in tune to the medical issue that you have, which was type 1 diabetes, and being in sales, pharma sales. You're clearly probably up on some of the medications. Just for our listeners, what medicines were you on, in the sense, did they have you on a baby aspirin? Were you on a statin? Were you on the typical medicine, the quote guideline directed medical therapy that we recommend? Because that, I think, helps prevent some of these things, but oftentimes, doesn't and can lead to, obviously worse consequences.
Yes, I was, along with my pump and CGM. I was on aspirin, baby aspirin, for years. I can't even remember when I started that, as well as statin, which came later on in my diagnosis time frame, but it was always recommended that it would help along the way. So I was on those medications. And then when I was diagnosed with the PAD, I was on, was it gabapentin?
For the neuropathy, probably.
Correct.
Yeah.
So that's, I was aware. My foot, I got to get this taken care of. So of course, I go to the podiatrist. I didn't have a normal podiatrist that I went to. I knew I had to wash my feet, but I did not go to the podiatrist until that blister, the callus came up and it became a wound. And the podiatrist brought me back and opened it up. And from that point forward, it never healed. So it stayed open. It was recommended that I, go to a different wound care center. I was originally diagnosed and given the fact that I was had some blockages, I was on hyperbaric chamber for the first 2 months.
So you had the hyperbaric chamber without having the revascularization first?
I had no revascularization.
See, that is one of the issues that I've been told by podiatrists is you don't put someone on hyperbaric chambers if their circulation is an issue without making sure the circulation is no longer an issue. Is that your finding as well, Dr. Phillips?
No, well, I mean, so there's sometimes they work in conjunction, or like together, and oftentimes in parallel. We'll have, so first, Robert, we need to at least kind of discuss whether, it sounds like you were diagnosed with peripheral arterial disease. I'm not sure how that was diagnosed, but then we should get into that. But, sometimes patients don't have evidence of significant large vessel disease, and with severe small vessel disease, which I imagine you would have with having diabetes, type 1 diabetes for so long. I don't think it's wrong to necessarily do hyperbarics, but typically we want to, at least the way we do it, is assess them and then get them revased. And if they're not a candidate, then we can consider hyperbarics.
Right. Well, I was diagnosed, and that was the first step for me. was the hyperbaric chamber. They sent me to the hyperbaric chamber in that particular hospital. The head of vascular surgery was retiring, so there was some new people coming on board. The wound care center was fairly new back then. This is 08, 09. And the amputation was 2010, so it was a progression. So as I was in the hyperbaric chamber, that wound continued to deteriorate.
And coming up right here on the Heart of Innovation, we'll find out what happened as this wound continued to deteriorate. Don't go away. You don't want to miss more of Robert Parant's journey. So stay with us right here on KDOW.
3 years ago, my symptoms started with leg pain and leg cramps while walking.
Me too.
Okay, that was great.
Yes.
Okay.
Your head is still getting cut off at the top.
Mine is.
We can go higher where.
And yeah.
So
And
Robert,
yours slipped down, Robert. There you go. Keep it. Can you tilt down a little bit, Robert?
Yeah.
A little bit more. There you go. There you go. Perfect. Oh, much better.
Okay.
so Robert, can I ask, did you had the ulcer? What kind of testing did they do to assess for PAD? And it doesn't sound like you had an angiogram or anything.
MRI. No, I did have angiograms, and I did have the pressure cuff
Okay.
test. I don't know what it's called, but
The ABI. So your blood flow was okay?
they found a spot past the ankle that was being blocked, and at one point in time they wanted to do a bypass. So they,
Well, because so sometimes folks with diabetes get what we call a diabetic ulcer, a neurotropic ulcer, where it's not related to arterial perfusion or flow. In those cases, if I'm concerned about it, we're very thorough about making sure that their blood flow is okay. But most times, and it sounds like in your situation, into the ankle, I mean, we can open that up. It might stay open for a couple months, maybe long enough to heal, but it's not a very durable procedure. And it sounds like this was more maybe a true diabetic ulcer than anything else.
I would definitely agree with that.
Okay.
So with a real diabetic ulcer, then the hyperbaric chamber is, yeah. But that's where I always say, whoopsie,
Yep.
I think your camera is following you every time you move. So now you went right. See, it's now, it's climbing. It's literally, it's creepy.
It is. I think it's like this. Hold on. Let me see if I can turn this off.
Oh, that's nice.
That's center. Yeah, that's the center. Well, this is so that. Yeah, that's the MacBook. Whew. I can do studio lights. No, we won't do it.
Ooh, I like that. I need you to tilt down
Robert,
though, because
that too. Robert, your frame is a little high. Can I get you to tilt that back just a scotch? It's an overcorrection there. There you go. Not too far. There you go. Let go.
Good.
Yeah. Mouth, nose, center frame. Perfect. Thank you.
oops, now you just set back a little bit, but there you go. It's just, I like it when I edit it and I put it into a different frame later when I re-edit it. It's just, I have to keep cutting one frame to the other. Size people. Thank you, Chris.
Okay.
So Robert, we'll just continue the conversation if that's okay.
Sure.
And if anyone has any questions, also you can raise your hands who are in the studio audience. I know we have our good friend Sally came back. Dr. John, remember Sally?
Oh
She's
yeah,
back.
from South Africa, correct? Yes.
Yeah.
KDOW.
It's so nice to see a smiley face. Here we go.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
And we are live on KDOW and streaming on YouTube. So happy to have Robert joining Kym and myself. So Robert, let's continue the story. It sounds like you have the foot ulcer, and I do want to dive a little bit into what degree of potentially peripheral arterial disease you have, because during the break we were talking about sometimes patients have what's called a diabetic foot ulcer or a neurotrophic ulcer that actually is not really related to lack of blood flow in the large vessels, sometimes the small vessels, and which is maybe why they pivoted to doing the hyperbarics. But regardless, it sounds like the ulcer got worse, and so now they're recommending an amputation. What was amputated? Was it just the toe, or did we have more loss?
We started with the toe. Prior to that, though, I went into New York City to one of the supposedly best wound care centers. And during that time frame, it was a nightmare because the vascular guy was involved, the wound care doctor was involved, and somehow a plastic surgeon was involved. So they kind of went up against each other, left it up to me. You decide what you want to do. So it was 6 months of debridement.
Did you know enough that that's for some patients? And sorry to interrupt you, but I think it's a serious point. For some patients, when we make that call to them or that option, it's overwhelming, and I don't know that they would know enough. How do you choose? It's like someone giving me a legal document and being like, "Hey, why don't you interpret this without a lawyer?" Maybe not that extreme, but did you feel overwhelmed, or what are you thinking?
Absolutely overwhelmed. We went to them for advice, and they were almost arguing amongst each other which one had a better way of treatment. So the wound care guy wanted to do debridement. The vascular guy says, "You're going to come back to me sooner or later. I see this all the time. You're diabetic. Looks like you have blockage in your vascular system." And plastic surgeon somehow got involved and said, "I can do a skin graft, take the skin from your thigh and put it over the wound, and we can heal it. You decide." So it was really a very scary, fearful, frustrating, scary time as to what do I do? I'm an active guy. I've been doing things, my whole life, riding bikes and staying active, walking around with a job and have to stay active. How in the world, at whatever age I was, 57, am I going to live with a lost leg?
And that must be also frustrating for you to think when we started out this show and Dr. Phillips is saying, get out there, be active, go do this, go do that. It's going to reduce your risk. And here you are doing everything right, it seemed. You were keeping your A1C under control. You were out there as active as you could be, and even more active than most people, even half your age, likely. And yet you are still experiencing these circulation issues.
Correct. And it's kind of a slap in the face, but as with anybody else that has issues, we have two choices: is to find out about it, try to educate yourself and deal with it, or not deal with it and run into problems.
I would argue that your level of activity saved your life. Yes. I would argue that, because if you were sedentary, and we're still waiting to hear how much was amputated, because I hate when anything gets amputated, but I would argue that saved your life. So, you did everything you could, and it's the cards that you were dealt. You played the hand, and, here we go.
100% in agreement, along with 52 years of type 1 diabetes. So that's what I try to do. I try to make myself an inspiration that you can live with this disease, diabetes, and you can live with a limb loss. Not easy, but it can be done and is done by a lot of people. So at the time when I was even at the time, it wasn't the leg, it was just a toe. It's just like half of the big toe where the wound was. So they did that. And I don't believe I got very good follow-up. So I don't think she wanted to see me for 2 weeks. And not too much follow-up afterwards. So that continued to get infected and not heal. So that's when I went to another vascular guy, and he said he wanted to take the rest of the toe off. which was, okay, so then is that going to really heal me? I mean, I'm having a tough time heal from the first one. How am I going to heal with the second one? And it took the knuckle off the big toe, and I have pictures, and it's just horrible to see. So that didn't heal. Back and forth with him, and led to infection in the wound, which went to osteomyelitis, which went into my leg. And next was the first amputation, which was July of 2010.
And this is such a vicious cycle. We're going to continue on with this conversation right here on KDOW in the Heart of Innovation. Don't go away. And this is our last, so we want to get to ultimately. So this is where, Dr. Phillips, it may have seemed to start out as maybe a diabetic wound, but there were blockages in the leg that were not addressed. And so the more they were amputating and amputating and amputating, the wound was just getting worse and worse and worse because it didn't have, I guess, the main circulation coming down. Is that right, Robert? And then you ended up with a below knee. Did you at any point have any sort of revascularization attempted?
No.
Yeah.
So
I had 2 revisions as well, because
they never. You had an angiogram where they put a catheter in the arteries and looked at the blood flow, correct?
I don't think so. I don't recall it.
Okay.
See, this is what I'm saying. This is why I was like, and then now his doctors are saying, well, it's too risky for them to even do it now, which I'm like, well, they never even did it in the first place. So it's just not even following PAD management guidelines.
Well, I mean, again, you have to remember this is 2010. So.
Yeah. Well, we're even talking now because they won't even go back and do it where he's having issues.
Oh, you're having issues with the stump or the other leg?
Stump.
Yep.
Claudication.
Yep.
Because it's such a small residual limb. I had 2 revisions after the first amputation.
Tell you what, Robert, you come see me. I'll take care of you.
I would love to.
I told him Dr. Runback is over there in Orange, New Jersey.
Actually, Robert, I would love to see, if you don't mind, and we can do this off air. If you gave me permission, I would love to review your medical record and just kind of see what it is that they're looking at, and I can help guide you.
Yeah, I can connect you guys.
Wow.
I think Dr. Phil, I'll just connect you guys again.
Yeah.
But we have, this is like,
Oh, yeah.
I think a 9-minute segment. And so we got to get to, because also, I mean, he started out as a diabetic advocate, and now he is in the lessons that he wants people to learn through his experience.
Okay, let's do that. So Robert, can we we'll go to it's July of 2010, and now you're kind of forced with a major amputation. We'll talk about that for a little bit, and then let's go into how your life has changed and how you're obviously trying to inspire others who are amputees.
Okay, we have 9 minutes with that.
Yeah.
There.
How much time before we go on live? Can I go get my water?
Yeah, you got time.
Okay, thanks. It's probably too early for a beer, right?
Oh, come on. I mean, you have the Irishman here. So actually, I think too, where's Joshua? I think Joshua would be totally into that.
I have to show you my leg.
Look at that. He has, that is so cool. He's got a shamrock. Joshua. That's so funny. That's awesome. Yeah, we have about 9 minutes.
Okay.
And then to kind of get through the story, we can, after the show, we could always add, if more conversation, we can take about 10 minutes after the show to add to the conversation if there's more. And then I can edit it into the online show later. So we'll see how it goes. We'll wrap things up at the end of this segment. Thank him, so much. And then our last segment we're talking about lithotripsy, right?
That is a 12-letter triple bonus point. Booyah! Hold everything. Spenducation? That's not a word. Yeah, it is. I spend a lot of my kids' education, so it's
Thank you.
Cool.
Yeah, I'm still struggling with this a little bit, but I feel like there has to be some reason for no angiogram.
Mm-mm. I see this all the time. I know you want to believe it, but I see this all the time. If you know that literally, I mean, 85% of the patients that come to us literally either no angiogram at all or no one will even try below the knee.
Well,
And so it happens a lot.
And I always draw the corollary, the parallel to coronary artery disease, where people will get a left heart catheterization for a hangnail, and let alone having symptoms, but yet, and it's, I hate to bring say the word malpractice, but we cover our butt so much with coronary disease that I think we do too many left heart caths. With PAD, and I still don't get this, and I think it's part of what Robert was saying about different, so many ways to skin the cat, and a lot of cooks in the kitchen, and it's almost a Wild West still a little bit about who gets what and where it's done, and whether or not you have your toes depends on where you live. I mean,
it does, but there's still a misfocus, right? I think that they're doing us a disservice to say that let's focus on too many procedures being done in the legs leading to amputation, when the real problem is still more than 50% or more than 60% of all amps without even a vascular evaluation at all.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thank you for joining us. We've got 9 minutes in this segment. I want to kind of get into Robert's advocacy and his mission now, but so let's rewind. It's July of 2010, correct? And you are facing a major amputation, right?
Correct. So that occurred July. It mainly due to osteomyelitis, an infection in the bone, which kept on moving up my leg. So after the July, I had 2 revisions in August and September because the infection was still there. In my opinion, the infectious disease people were nowhere around or communicated with me very, very clearly as to what they were doing. So it happened again in August and September. So after, I would say 3 amputations, and after each one, I was doing rehab. So I was doing my exercise, and I had to go back to the operation again. So anyway,
I want to drive it home the point that they had told you had a blockage in your arteries, but didn't address it according to PAD management guidelines, which is to at least try to restore inline blood flow prior to any amputation. They did not even try to open up the arteries at all, which if they don't open up the arteries, they're pumping in the IV fluids, the antibiotics, it can't reach the area in which the infection exists. So the infection just keeps spreading.
Right.
Well, I mean, the other thing too is typically once the bone gets infected, and I mean, we can sometimes heal a toe, but if your heel is involved, I mean, that's pretty much game over. So I don't know how far. You must have pretty extensive osteomyelitis.
Kept spreading. Yeah.
They said sepsis after the first one. I needed a wound back. I have some pretty ugly pictures. The whole thing.
Wow.
So, again and again, August and September, and then rehab, and I'm diabetic, so I do not heal that well. So it was not until January I got a prosthetic. A few issues with the prosthetist or finding one. So that's a whole nother area of discussion, is finding a good prosthetic guy, which I did, and finally got to walk in February of 2011.
And so you started out as a diabetic advocate, and now you are becoming an amputee and PAD advocate.
Correct. I avoided it for a little while because of stigma. You had diabetes, you didn't take care of yourself. And diabetes is not a visible chronic illness, but your leg is. So people ask me a lot what happened, and I always get the response that you didn't take care of yourself.
Which is not true.
Not true at all.
So you said enough. I'm going to fight this. And you did, or are, right?
Yes, absolutely. Absolutely. So that year, my son and daughter-in-law did the JDRF ride, which is a diabetes organization, in my honor in Death Valley. So I went. As they crossed the finish line after 100 miles, I cried my eyes out. And the organizer of the ride, I met and was so honored, and with my son and daughter-in-law and everybody else that was riding for diabetes, I said to the coordinator, I'm coming back next year and I'm going to ride. So my rehab was all in line, very strict, very organized, getting back in shape, getting on a bike, riding the bike pretty much every day. I would go down the park and ride for miles. I did 65 miles in Burlington, Vermont, my first ride in 2012, and got the Spirit Award that is the, inspirational person for that particular ride. From that, I started to tell my story a little bit as advocacy. I didn't go back to work. I did try, but I did not go back to work. I went to volunteer with JDRF for 9 years, which was helping all diabetes in all areas. And then I started to do advocacy as my story got out there. I went to training for how to talk to people in Congress. Then I did Hill Days, which we were trying to pass bills for less cost of insulin and different policies and procedures that diabetes laws that are taking place.
Tell us about going to the White House. And I saw a great photo with President Biden right by your side as you were speaking.
Yeah, that was quite a experience. I was asked to introduce President Biden in the White House in the Rose Garden, September of 22, when he announced a $35 insulin and for Medicare and the Inflation Reduction Act. So I was with him in the Rose Garden as he made that announcement. Quite an honor, and that's what I've been doing. I've been fighting to try to get insulin prices down, and for my senior friends as well. So I felt very honored to be that person to get that done and to be the one to introduce President Biden.
And so in the last few seconds here before the break, if you could wave your magic wand and make anything possible for diabetics, PAD patients, and or amputees, what would it be? What is your next goal?
Next goal is early on screening, I would say. Early on screening and get your foot exams as part of a regular organized visit. Whether it's your eyes, your heart, everything with diabetes has to be checked. And your feet are the furthest thing from your heart. And that, circulation is key. I think the exercise, as Dr. Phillips had said, kept my blood going very quickly through my system, and the gooey stuff, which is what happens when you get high blood sugar, sticks against the walls of the veins and arteries. So I believe exercise, moving your body as much as you can, get screened, get noticed, and if you do have an issue, get to it right away. Do not wait. It happens quickly. It moves quickly.
I have a feeling he is going to be the next face of the ARC Act, which is in front of Congress right now, which is, you're nodding your head, yes, where they're looking to make sure that early screenings are available and covered by insurance for those who are at greatest risks, especially diabetics.
Yes, and covered by insurance is the key.
And I know
people aren't going to go if it's not covered.
I know we've got to go to break, but I'm looking at your photo in the Rose Garden. and you look like a stud up there, man. Like you got the seal, the presidential seal, the two microphones. I see Biden in the background. Man, I got goosebumps. That's awesome. Awesome.
And Robert Parant, I wanted to, is there any way people can follow you and follow your journey and get involved if they would like? Should they go to LinkedIn, or where should they go to find you?
I'm on LinkedIn. I don't have a website or anything. I'm just a regular guy that's out there trying to help others with diabetes and definitely amputations. It's very prominent to see that there's not that middle step of screening and getting people under care quickly.
We'd love to see you helping us with our advocacy efforts as well. Thank you so much for all you do to create the change we all want to see with diabetes, PAD, and amputee care. Thank you so much, Robert Parant. We really appreciate you joining us. And coming up next, right here on the Heart of Innovation, we have a brand new segment. It's called Spur of Innovation. So you don't want to miss that. Stay with us. That was really good.
I'd like to hear more about the whole, we got to have Robert back on, because I'm curious that whole process of getting in front of, like, how do you get in front of Congress? And not only, well, first of all, most people can't ride 65 miles with two legs, let alone one good leg and a prosthesis. And then to do the 100-mile race or ride, which it sounds like you did, Robert. I mean, and you're probably close to 60 at that time?
Yeah.
So, I mean, dude, you're killing it. Like, seriously, I love it.
Well, I appreciate that. And I do work hard at it and always have. So that's my mind.
Because you don't look like, and I hate to say this, right, but there's a phenotype of people with diabetes. And now, with being diagnosed at 19, I would be curious to know how many people have lived with no inability. So the pancreas does not create insulin for Robert, as opposed to like problems with insulin sensitivity in type 2. So how many people live with, for how long? What you said, 50, 60 years of type 1 diabetes? I mean, you're maybe in some rarefied air there, I would imagine. So, and it has to do with, I believe there's genetics there too, but the fact you were so active, that probably that's got to be part of it, I would imagine.
I say it all the time. I talk about circulation to people. Keep your body moving, get circulated blood. You got sticky blood because you're diabetes and it's sticking to the walls, and move it and get moving. And I believe the same thing, Dr. Phil.
Yeah, man.
Yeah, and we do have probably some questions coming in. Marcia, if you can wait till after we're done with the whole show, and then we can get into some questions. If Robert, do you mind sticking around for a few minutes? John, can you stick around for a few more minutes after the show? Just maybe 10 minutes, so we can do that
after the next segment.
Yeah, and then John, I was thinking just, if I could start this segment.
I hope you were going to. I was like, you better.
I was just going to, because I think it works out better, because I'm literally kind of the journalist and you're the, physician. So I almost feel like it's me kind of stating what the news is, and then you kind of feeding into your thoughts,
Sure. Yeah.
You know what I mean?
100.
Okay. You're my expert.
Kind of. Well, the advice is worth what you pay for it, and this is free advice, so that's what you got.
And remember, the advice and views offered on the show are that of the opinions of those who are on the show. Always check with your own healthcare provider.
No, but I mean, like that picture, it looks like a nice day out there. You got a sharp navy blue suit on, cool looking tie. I mean, looks good.
Funny story about that suit, I'll tell you some other time.
All right. So, we're definitely having you back on seriously.
The first,
I think that would be fun to just go into all of your, like, write down, all of your different experiences, like, because he's also involved in I think some stem cell stuff.
Diabetes Research Institute out of the University of Miami down in Florida. They've been around for 50 years doing work, diabetes only. It's an institute specifically for diabetes, and they are now doing cell work, cell therapy, encapsulation.
30 seconds.
So very good organization as far as cell therapy research.
Here we go.
It
Can you
looks-
mute, Robert?
It looks like you guys might not have a full 4 minutes. Is that okay?
That's fine. Just keep us where we're at.
Keep us honest.
All right. You still want me to do the voiceover?
Yes, please.
Okay.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
It's time for a spur of innovation, new ways to save life and limb.
Well, hello, everyone. This is going to be our new segment, Spur of Innovation, brought to you by Reflow Medical and the Global PAD Association, where we are going to be featuring every week a new technology, a new advance, a new tool, whatever it might be for cardiovascular and vascular health, something to save life and limb. Abbott is launching intravascular lithotripsy, and they're starting this trial aimed at clearing the coronary arteries. Lithotripsy, it's the audio waves that crack the plaque, and you may be aware of it because it's been long used to crack those kidney stones, right? And now it's being used in the arteries as well to crack the plaque. And Abbott is getting into the world of this. It seems like so many companies have followed the pioneer, which was Shockwave, in this space. Dr. Phillips, what do you think? I mean, everyone is excited about lithotripsy.
Yeah, I mean, we've had lithotripsy, I want to say probably, at least 8 years, 9 years or so. It's evolved. Shockwave was kind of paramount in developing the first balloon that we could use in the peripheral arteries. And then they modified it to work in the coronary arteries. So why do we need lithotripsy? It's for heavily calcified vessels that it's kind of like when you walk in a cave, there's stalactites and stalagmites, creeping up at you from above and below. And it's hard to walk through that. And imagine, the artery looks like that. And we've got to try to fix a blockage and put a stent in or some scaffolding. So you got to shave that stuff off or at least crack it a little bit. And that's what lithotripsy does. There's a lot of companies out there getting into the space, and Abbott is one of them. Looking in the coronaries, clearly they'll get into the peripheral as well. So it's exciting times for us. Again, just having new technology that's helping patients maintain better perfusion, maintain saving their piggies, maintain, obviously from a coronary standpoint, good cardiovascular health, and it's really exciting.
And when a patient hears this, are there any key questions they should ask their doctor about this technology?
I mean, again, there aren't too many patients that come to me and ask me, like, do you do this, or this? I mean, I pretty much tell them, hey, everybody's different. We assess you as a patient. We assess, your blockages, individually, and we have tools to treat them. And I mean, sometimes certain labs won't have the equipment. And so, we have to transfer folks or whatever, but, just be aware of it. Honestly, it's not like some people ask, does it hurt? I mean, do you feel it? You don't typically feel the shock waves because it's basically a hydrostatic kind of wave that's created that kind of reverberates and breaks up the calcium. Very, very cool technology. There's probably 3 or 4 other companies out there that are going to be on the market at some point soon. So it's not going away, that's for sure.
Fantastic. Thank you so much, Dr. John. Thank you, everyone, for joining us. We really appreciate you being here right here on the Heart of Innovation on KDOW. If you want more of this amazing content, you can join us every single Saturday on KDOW. You can also subscribe to our YouTube channel, youtube.com/@thewaytomyheart.
Thanks, everybody. Well, we can keep talking if we have a couple minutes to kill, 30 seconds to kill. What else is new? What else is new?
I know.
What's spurring your
We
mind right
always-
now?
The funny thing is that we get so many questions when Kym uses her small print lawyer speed reading. What am I speed reading? Small print lawyer speed reading. What was I speed reading?
Oh, that's disclaimers probably, or
Oh,
you
my
can
speed
follow
reading.
up.
Oh. Oh, that's closing the show.
Okay.
So I get a lot of
Is that a
patients.
wrap?
They post. So you may not get the questions, but they're always posting in the group about lithotripsy, about different technologies and things like that. And so, we're getting a lot of questions right now about PTAP. And so a big milestone is they just hit for PTAP that new minimally invasive bypass, which is interesting for non-surgical candidates, especially type 1 diabetics, that if you can't have a regular bypass, there is this newer option available. And it's nice to see that they have more than 1,000 cases now under their belt and have a broader patient base to be able to make sure it's actually going to be something that could be durable.
Yeah, it's not for everybody, but again, it's just, I think it's important in general with life and your health to have options and be aware of what the options are. And I don't have a problem.
KDOW, streaming now on.
Are we good?
I don't know.
Oh.
Hey, Chris, were we out when I said we were out?
You guys went a little over, but I kept recording for the podcast.
Okay, because usually I just need to know when we didn't hear any music.
Yeah, it stopped playing and I couldn't get it back. So,
well, we didn't hear it at all.
It's because you were still talking, so I didn't turn it up all the way. So,
because I just keep talking until I hear, because usually I'll hear the music. And so I was like, or at least something.
Yeah, I guess I misheard the volume.
That's okay. If you can let us, maybe we figure out a better way that we can, maybe when I see the 30 seconds, I'll literally just close.
Okay.
Yeah, thanks, man. Well, because the two of us will talk forever.
Yeah, you can tell. But thank you for recording it.
Yeah, thanks, man. Appreciate it.
Yeah,
but no, what I was saying is I think it's important for patients to have options and, ask their physician or surgeon or interventionalist how many procedures they do or what is their area of expertise. I don't take, offense to that. And I think it's important for patients to know that. And because you want to be in good hands and you want someone with experience and you want someone who knows enough to say, you know what, maybe I'm not the right doc for you, but I can get somebody for you. Set the ego aside, do what's right for the patient.
It was interesting. I had the call that came into our Lifesaver hotline this morning. It was great because Dr. Gregory Hayes is the head vascular surgeon at Swedish in Seattle. He's been my go-to. He goes out of his way for his patients. He's one of those vascular surgeons that literally just try to exhaust all efforts for the legs and have all the toys available. And I said, hey, this patient came to me with another doctor. Do you know this doctor in your area? And what was amazing is that he was able to say to me, hey, there's this interventional cardiologist. It's great. He's not the most advanced, but he knows when to say when. He does what he can. He does the initial for me. And he always calls me. He said, we're in frequent conversations because, he likes to make sure that there are options beyond himself in case he can't do something. And so I thought that was really awesome.
No, it's
the way that they work together.
We have worked really hard to try to break down barriers within our health system. And I think we've made some strides, but physicians are alphas and egos get in the way sometimes. Mm-hmm. And let's be honest, it affects patient care. It shouldn't, but it does. And I'm not perfect by any stretch of the imagination, but you see it and our patients see it. You guys see it.
Yeah. The worst is when we have doctors that will badmouth other doctors simply because they're in a different practice. And our patients come to us and they say, actually, I won't go back to that doctor anymore because I don't think it's right that he's bad mouthing another doctor. It just shows his insecurity. And I was like, wow, perceptive patients. But we have that patient that's over at Tampa General right now. And what was so frustrating is that original hospital had 3 vascular surgeons that just kept trying to course the patient and telling them that this was their only option. And this is why I always say to patients, it's so important to get multiple opinions prior to any procedure. I don't care if you're going to the best of the best, head of vascular, head of interventional cardiac, head of whatever, great reviews on whatever. Your referring doctor says that they're the bomb. I don't care. But what if they don't know what they don't know? What if in this fast moving space where innovation is happening, especially with PAD at the speed of light, right? You see new stuff. It's hard to keep up. You're right there on the cutting edge. You're right there at the forefront.
It is and it isn't, though. I mean, like the tools are pretty much the same. It is, in my opinion, the ability of people to kind of think outside the box and try to be as appropriately aggressive as possible with the patient and be honest with them. So, I mean, I think that docs just have to get out of their own way sometimes. And it's unfortunate that patients have to be the quarterbacks of the care and say, hey, like, I don't agree with this or whatever. But one of the issues is when you're in a hospital, you can't, I mean, it's hard for you to leave. So, I mean, where are you going to go? Like, you're kind of stuck there.
Yep. And I'm dealing with that with someone in Lexington, Kentucky right now, because
that's only 3 hours from me. So we can do this and help.
She is, if her insurance will cover you is the only thing. And she is I wish I could get her transferred to you, but she is like Robert, and Robert, everyone can join the conversation. Just like Robert, she's a diabetic, except she's type 2 diabetic. She has an A1C above 11. She's been able to get it down, quite a bit to there, but she's blocked back up, had a couple revascularizations prior to where they clean out the artery using wires, balloons, and possibly stents. Now they want to do a bypass because she has wounds in her foot that won't heal because they said the other stuff just hasn't been durable. And the conversation that we had this morning is like, well, what did they tell you about the durability about that bypass with an A1C above 11? She said, it's going to fail. And I said, so why don't they let you out of the hospital, go get another opinion? She says, no, they're going to force me to check out AMA against medical advice unless I go and do this bypass. And I said, but why are you going to do the bypass if they said the bypass is just going to fail and lead to amputation? She says, they're really holding me, she used these words, she said, they're really holding me hostage here because I can't do anything. And I said, well, here's what you're going to do is have a candid conversation with them in a language that I think they'll understand, which is, why don't we go back in? Can you go back in a minimally invasive way, suck out some of that clot? Because doctor, I promise you, I am going to work on that A1C. I'm going to get it down. Let's just buy me a little bit of time so that when this happens again in maybe 3 months, I will be ready for that bypass and it may be more durable at that point. So you're not saying I'm not open to a bypass. Let's just maybe wait until I can get to a point. Let's put a Band-Aid on it right now. And then let's do something major later. Let's just keep kind of kicking the can down the road a little bit. So she's going to try that. But yeah, if she can get out of there and then we can get her to you, then I'm sure and her insurance covers it. I'm sure you could get in there, but even you don't want to go in when someone's blood is thick and sticky and it's just going to block right back up afterwards.
Well, I mean, again, there's a lot of factors that, in my opinion, that play into whether or not somebody's going to have a durable result or whatnot. You have to, and I find myself falling into this trap too. You try to remove biases from your thought and judging people. But again, when I hear an A1C of 11, I'm thinking that blood glucose level, and Robert, you know better than I do, is probably hovering around 250-ish. And that's not good. And like that is, but see that in, how do I articulate this without sounding like a jerk, but I probably will. When you see that, it's kind of like this person is not taking care of themselves. Okay. They need to take better care of themselves. The same like the gentleman that we took care of the other day who kept smoking. It's like, buddy, you got to stop smoking. God helps those who help themselves. And so physicians are human, and there are biases and judgments that come in to play. And, I can't speak for the docs that are taking care of her in Lexington, but I would imagine there's some thought like, well, what's the point? I mean, what's the point?
Yeah. And that's kind of the thing. But the best thing that the doctor likes to hear is, hey, I want to be a part of this plan. I want to be a partner in my care. And yes, I should have taken, especially I think it's harder with type 1s, right, Robert? I think, and even Sally, with type 2, though, for most type 2s, there are a lot of things that a patient can do. And even I said to her today, I said, so have you been eating right? And she says, well, yeah, I mean, I've been able to get it down. But being in here in the hospital, I mean, they just don't have a diabetic diet. I said, what do you mean they don't have a diabetic diet? I said, don't you have a choice as to what you eat on that plate? Oh, yeah. I said, well, you can just eat the meat and the veggies on there. You don't have to eat the bread and the potatoes and the rice and the noodles. Yeah, you're right. I said, so let's start right there. But they do want to give insulin. And people can wean off insulin, but maybe it's something that she might be able to do.
That is incredibly rare. That's why we always tell them, like, you need to get your metabolic syndrome under control. You need to lose weight. Because once you get on insulin, it is almost impossible to get off it. But if you're on meds, you can potentially prevent yourself from going on insulin. But Robert, if you don't mind unmuting, I am curious to hear what is next on your agenda with respect to advocacy, not only for diabetes, but also amputees.
Well, amputees is fairly new. I've been trying to get in touch and tell my story. Sally knows me from a couple of years ago, and we've been back and forth speaking to each other. So I'd like to get a little more involved with the amputation side of things. I am still very involved with Patients for Affordable Drugs. So trying to fight against the PBMs. I do Diabetes Patient Advocacy Coalition, all out of DC. And my thrust right now is trying to get more awareness to Diabetes Research Institute down in Florida, because they're doing such great work and nobody knows about it. But as I reached out to Kym and keep following, the docs that I see, Armstrong, and I've spoken to a couple of them via online, and I would do whatever I can to help in this area too, if I can.
Where's home for you?
New York, Long Island.
Oh, New York. Okay, gotcha.
We can put you in contact with the Cardiovascular Coalition. They're very involved with the ARC Act. Can also get you involved with the American Diabetes Association, with Chris Fox and the team there, to do some advocacy on Capitol Hill for PAD in particular, and the ARC Act, which I think is going to do so much to help get the word out there on early diagnosis being key and legitimizing PAD. I think it's going to help a lot. We also, as part of our organization, we have a brand new PAD amputee group, which we just started, which it's the only one that focuses on PAD. Several of our patients asked us to start it because they said so many of the other groups out there, there's a mix of people that don't understand diabetes and PAD and the difference that happens. They're like, oh yeah, what are you talking about? You get your prosthetic and you go, like, we're good. And that is not what happens, because there's so many different factors and how many different prosthetics that you have to change over and over again. And then, as Sally knows, the risk of stroke and all this other stuff, that they wanted to have a different group. And then on Sunday nights, Dr. John, as well, we just launched an amputee group, amputee support group. And we have quite a few patients. And so I'm looking for someone to kind of take the reins a little bit more on it, to help facilitate the conversation. So that might be something that's maybe someone can tell me, I think it's 7 p.m. on Sunday nights, Eastern time. And so I could definitely
I
use
can
some
help with that.
That would be great, because we just need help with facilitating the conversation. And each week, what we're looking to do is to, let people share and ask questions about their experiences and get support. But what they also want to do is start creating content through it. So taking on a topic in every episode where people share their tips and tricks. And then we're going to put it on our padstories.com website. And Robert, I can even give you, Sally has his own blog on there. I can give you your own blog on there. And I think Marcia might even have her own blog, which I don't think that we've gotten too many on there. But we just brought on another PAD patient who's a writer, and she is going to be taking over as editor of that website. And so she's going to be able to help and get be able to go, Dr. John, can you put some clinical messages in this
Cool.
patient's article and things like that. So would love to get you more involved.
Happy to help.
Whatever
You know that.
strikes your fancy. Yeah.
Happy to
But
help.
Dr. John, we are adding you to our medical board of advisors.
All right.
Not that you really
Should I be
kind of
advising anyone
anyway.
though?
No, but Aaron Armstrong is chairman of it and taking the reins. And so we were trying to figure out, because I had I had the committees, where we were doing, the editorial content and things like that in education, which I had you kind of leading because you're leading here. But we decided that we want you as a grander role, because you're bored and you have nothing else to do.
As like I said, if the patients will, if you're willing to fight for your leg, I will fight with you, and I'll do what I can to help. So Kimberly, just keep on keeping on. But Robert, assuming Kym allows this, we'd love to have you back on.
Sure. Very willing to help wherever I can.
Yeah.
I have been getting a little more, busy with some of the advocacy work after the inauguration, with some of the funds that might be cut. But absolutely, sure. See
because it would be, can you write down some of the advocacy stories, like some of the really cool stories to share of your journey with advocacy, the people you've met, how you were able to influence? Would love to talk a lot more about, and Dr. John, the institute, the research institute would be really fascinating.
Mm-hmm.
Maybe we have Robert on with someone from the research institute.
Yeah, I just was with the medical director the other night. He was hired 2 years ago from the West Coast. One of the most world-renowned diabetes specialists is now gone to Diabetes Research Institute. Dr. Matthias von Hara, very interesting person, and very highly regarded.
Yeah.
I can get you on with some of the DRI people very easily.
I'd love to hear more about how you got involved with advocacy in DC. I'm really interested in that.
Sure.
A bunch.
Yeah, no, it's a whole story, and it all happened after I lost my leg. I said, I tried to go back to sales, and I had this prosthetic, and I had a few appointments in the city, and I got a huge blister trying to get in taxis and in and out of taxis. So I said no, and that's when I started my volunteer work, and it was mostly helping newly diagnosed parents that have no idea what to do when their child is, a 2-year-old child is diagnosed with type 1. So I started out with that. I started speaking a little bit. I started to get involved with a gala, and then I was asked to be the ride coach, even with one leg. So I said, sure, I'll be the ride coach, and started riding. And then I went down to Washington. I saw a group that was meeting to understand advocacy and how to work within Congress to try to force support in particular bills in diabetes. Back in that time, it was mostly the CGM area, what CGMs were used for, how they were used, how it's covered. And from that, I met probably 15 people that went to that particular class. We all stayed 2 days for training, how to speak to someone, what they want to hear, who you're going to see. And then we went into the offices of the House of Representatives and Senate. You don't usually see the senator or that particular person, but you see somebody within their office and you tell them your story and why Bill XYZ is so important to the diabetes community. And then I've lived with it for 52 years and I tell my story. And, when we've gone in, it's always been, well, I have an aunt, an uncle that has diabetes. I, know some of these things about diabetes. And that's how I started telling my story. And it just grew, the fact that I was riding and, able to do 65 miles a couple of times with the JDRF rides and just trying to inspire people. So that's pretty much how I got involved with the advocacy. So I started out with Patients for Diabetes Patient Advocacy Coalition, and then Patients for Affordable Drugs. And that's all drugs, not just insulin or whatever. So that's kind of how I got involved, telling my story, and it seems to have resonated. I'm a quiet, stay-at-home guy that I don't have a blog or anything, but I do try to help others via the social media aspect of things.
For you.
Is that training group, is it still around? And how would a person get in touch with the group?
The training group.
What's its name?
It was an outbreak of the Patients for Affordable, Diabetes Patient Advocacy Coalition. They're still around. You still can join them. They don't have the training sessions down in Washington like I went to, but they still have Hill days and they still have days of training. So it's Diabetes Patient Advocacy Coalition, DPAC, DPAC. And that I would start there.
Yeah, but we have our own, Marcia, and you just haven't been involved in it. It's just that we have people that come to us and ask us for patients to actually, there's no training at all. It's just, give them straight to the Cardiovascular Coalition or the American Diabetes Association or other doctors that come to us and they say, hey, or companies, even Janssen used to come to us and they would say, hey, we need patients with this demographic, this presentation of disease to speak on Capitol Hill. And so they have very specific things that they look for. And so they come to us and they say, hey, do you have a patient that fits this profile?
Sorry, guys, I got to run. Cheers.
You can go ahead. Thanks so much, Dr. John.
We'll see you. Thanks, Robert. Cheers.
So I can add you also, to that list.
Please
as well.
do. Yes.
But also you should get in touch with Robert and Sally as well. I'm glad you are all here because, I'm just going to stay alive because I think this is interesting. Marcia is literally, she is like an idea factory. Last year, she came up with this brilliant idea to light a red candle for PAD awareness. And so we did the Light a Red Candle campaign and we came up with this great slogan and we sold a bunch of candles and people were lighting candles to raise awareness about walking as medicine. So this year, what this stroke of genius she came up with is we have a phrase called, rock your walk, meaning like music, rock your walk. Well, she took it in another direction, which is to literally rock your walk. And so she wants everyone to paint rocks with critical PAD messages across the globe and put them in the most vulnerable communities with our website, phone number, with what is PAD, creative ways to share what PAD is on these rocks, because they're small rocks. So you have to be a little more creative, and create like a journey for people as they're going along a certain path. It's leg pain, leg cramps, neuropathy, diabetes, things like that, and creating a little journey for people. and then putting padhelp.org, on it. And so we're thinking of doing this for the entire month of PAD Awareness Month in September. We're going to start preparing now and getting slogans and things like that people can use. So we definitely need a team to help us with this. But it should be pretty fun. And I think, Sally, you can lead the way in South Africa. And Robert, you could lead the way on the East Coast over there up top, Marcia's in Florida.
Okay.
Yeah, I'm working on a more detailed plan to help facilitate the launch of this thing.
Yep.
And I'll get that to you maybe later today or by tomorrow. I'm about halfway through with it. So I worked on it a lot yesterday while we were brainstorming because I was hot on the spot. So
love that.
I'll keep everybody posted.
Yeah, so would love to get everyone involved in that. I think that could be a really fun thing. We're looking at maybe using part of it as a fundraiser where we can send people a rock kit of 16 rocks and an acrylic pen group and make it almost a clinic, employee build, what do you call it? A relationship building thing, for community building thing for them, even putting them out in their waiting rooms and letting patients actually paint the rocks and put them out there, whatever it might be. Just, we thought it was kind of fun. So we always, with these ideas, we kind of let you take them in your own direction as well. So if you have a spin-off of it that we can, just make it a part of it, for different areas, then we're happy to include everyone and all ideas. Marcia's a really great collaborator. So whatever ideas you have as well. But Robert and Sally, what? Go ahead.
I'm just saying thank you for that, Marcia. That's great. If I can help in any way, let me know.
And would love to have you on Sunday nights if you can help with the amputee. Also, Sally. Sally, it might be harder for you because it is 7 p.m. Eastern time.
Yeah.
But
I don't mind, but the medication that I'm taking, sometimes it knocks me out.
Yeah.
So, and
I need some of that sometimes.
It's just that, with the stroke that I had, I have to put the dots, together and formulate my sentences properly. So I would love to help, but not in a very, very active way, maybe with some ideas, but listening to Marcia and Robert, with all the experience that they have, and it's wonderful. It's really wonderful, and just on a short, quick note, thank you, Kym, for sending all those patients to me. It is, how can I say, they're from South Africa. It was situations where they were suicidal.
Yeah.
And I wanted to ask Robert more to speak on, like myself and Robert will always speak about the emotional side of the amputation and our diabetes, the complications and everything. And just thank you, Kym. That's all I can say, because with my story that I gave over to them, it actually saved their lives, just motivating them a little bit. And they're not thinking in ending their lives. They're thinking on living and sharing their story.
Wow. Well, I thank you for being there and being a peer mentor for these patients in South Africa that I can send people to. And it means the world to me to have you a part of our team and being willing to take time with these people and share your story and inspire them and let them know that you can still thrive. You can still live. Life may be different, but start fresh.
And you using the word thrive, and I've just changed my slogan from suffering to thriving. you
Good for
know.
you.
And Marsha was speaking of I always use the word condition, and we were speaking about the situation that we actually when Robert actually spoke about stigma and stuff, it is a situationship, that we can't be blamed for that situationship.
Yeah.
We can take it forward. And what Robert, when you speak about the exercises and things, this what saved my life because of that stroke. And if I didn't do the exercises and I didn't eat well, I'd have probably be in a situationship where I could have been a vegetable,
Yep.
But the motivation and things, it is what it is, but we can't be blamed for it. But thank you, Kym. I appreciate. I follow up on them on a daily basis, and they're improving. They are improving. Okay.
Amazing.
Thanks.
That's so beautiful. Thank you, Sally. And Robert, if you have the opportunity and want to become a peer mentor as well through our organization, we would love to have you for folks here in the United States as well that are going through this.
Sure. I am.
Sally.
Oh, I'm on mute. No, I'm not.
You are.
I'm
You're
live.
fine.
Okay. Yes. No, I would love to help. And I am, like I said, getting involved in a lot more than I ever did, but that's okay. I can help and get on certain times, and that's what I'm looking to do. And I think that's why I've reached out to you a few times, and finally I'm ready to go.
Yeah. We'll plan the next show. Think about another key, maybe we try to key off certain activities or time, just timely things. So if there are things that are happening with the Institute or whatever, that just let me know, and then just let me know what Saturday that you both could be available. Or if you want to come back because you have a lot of great things going on, then we can have you on again. Or, I mean, it's always during Diabetes Awareness Month, if that's not too long away. It's just around the corner, right? In November.
November, yep.
Yeah.
We can always do something with that as well. One of the things that we try to do is we try to create seminars, like on World Diabetes Day, maybe doing a 2-hour seminar where we gather a few different doctors and a few different patients to share their story, and the doctors, some endocrinologists, whatever. So if you want to help plan that, that could be really exciting as well, and help kind of co-host that.
Okay, good.
Sally, Robert, just something that I thought of. My wife died from younger onset Alzheimer's disease. She was 67, and she was diabetic. And she didn't have to go on the injectable. I forget what it's called now, but she just took the metformin. But there's a lot of discussion about the link between diabetes and dementia. Some people even call diabetes
predisposed to.
Well, no, there's a phrase they use. It's like type 3. Dementia is referred to as type 3 diabetes in a lot of circles. So I'm interested on any of your thoughts about this.
I've been reading about the Alzheimer connection. I'm not that able to speak on it in detail. I know there's studies and a lot of research being done on it, but I know it's a prominent piece of the diabetes puzzle that a lot of people are starting to see now. But I don't have that information available to tell you, Marsha.
Yeah, it is a puzzle, and there's no cure for it, and there's a lot of theories out there. Some of them are just a lot of hogwash, I think, from my decade-long experience being a dementia care partner. But I too read a lot of things, and I don't have a conclusion about the link. There isn't one yet.
Right.
So,
Sally might know a little more.
any thoughts, Sally?
Yeah, I mean, there isn't a lot of clarity on. I know they're trying to rebrand, if I may call it that. There's a lot of ADHD for the children. It's also related to diabetes, dementia. There is so many things that the research that we did with the IDF, the International Diabetes Federation, and with the EASD, the European Association for the Diabetes Studies. So, um, like Dr. John was actually saying, and Robert, in fact, Robert was saying, when they start actually arguing on what could be the cause of it, but they still don't have clarity or how to brand it or how to actually segment that dementia or Alzheimer's, ADHD as all related to diabetes, and now wanting to rename it to type 3. It is so, it's not confusing. It is just that there isn't actually a concrete conclusion on naming it, as some people are actually stating. So again, like diabetes for the last, Robert and I, Robert 50 odd years and myself 43 years of being a type 1. And it is just that how are they going to classify, or when are they going to classify things in the correct group? And how are they going to do it? So to answer your question, Marsha, there is a lot of uncertainty. Okay, and if you want to call it hogwash or anything, that will be your opinion. But there is so many things and studies going on now at this moment, which is still not clear. There's still a lot of material to be read on. And I would actually stay clear myself. From my opinion, I wouldn't want to brand it or name it under anything yet. I wouldn't.
And it's so important to also, in all of it, stay neutral, because medicine is still a practice. Innovation is moving at the speed of light across vascular and cardiovascular medicine. And it's really important to, stay on top of what's new and what's next, and making sure that your care team, says, hey, I don't know what I don't know, but I know that there are things that I may not know. And always make sure that you are, before any treatment, with any diagnosis, you always get a second and even a third opinion from different areas. If you can, different networks, if you can, different clinics, different hospitals, different practices. There are 4 different types of practices that treat PAD in particular. For example, vascular medicine doctors, interventional radiologists, which were the first to do the interventional practices in the legs, interventional cardiologists who realized that, well, if we can actually take wires and balloons into the heart with a moving target, then why not into the legs and the straight shot? And then you have vascular surgeons who can do both minimally invasive and surgical methods to treat PAD as well. But with any of these practices, they might have a specialty. They also may not have every tool and technique at their fingertips, because again, we're moving at the speed of light with all kinds of new innovation and tools and techniques. So I think that we're going to leave you with the fact that medicine is evolving, and it's up to you as the patient to make sure to advocate for the best care for you. And don't be afraid to stand up and say, hey, you know what? I want to explore all options available. I like you, doctor. I like you, healthcare facility, but What if there is something else? What if there's a trial elsewhere that might offer me a different option? You have a right as a